And with that, I will hand it over to Dr. Mizukami Stout and Dr. Iyengar. And to give a brief introduction, Dr. Mizukami Stout is an assistant professor of internal medicine with an appointment in the Division of Metabolism, Endocrinology, and Diabetes. She attended medical school and internal medicine residency at the University of Colorado. She then completed her endocrinology fellowship at the University of Michigan and joined the faculty at University of Michigan in 2017 and has a dual appointment with the Ann Arbor VA. And Dr. Jenny Iyengar is a board-certified endocrinologist and a clinical associate professor at the University of Michigan in the Division of Metabolism, Endocrinology, and Diabetes as well. She's the primary quality improvement person for the Michigan Medicine Endocrinology Division and serves as a member of the Michigan Medicine Internal Medicine Quality Council and the Outpatient Diabetes Quality Improvement Committee. We're very lucky to have both of them here today to share their presentation on insulin and type 2 diabetes.
All right, thanks so much. Jackie, can you see my slides?
Yep, we can see
Okay.
them.
All right, thank you so much for that wonderful introduction. Dr. Iyengar and I are very excited to be here to talk more about the whens, whys, and hows of using insulin in type 2 diabetes. And with that, we'll just go ahead and get started. So we have four main objectives today. I'll start off by briefly reviewing the physiology of diabetes and insulin. And then in this era of exploding therapies for type 2 diabetes, we'll review indications for insulin use in type 2. And then Dr. Iyengar will take over and she'll talk more about the core insulin principles as well as counseling points for successful insulin initiation. So let's move it back to medical school to the human pancreas. So as you know, it's comprised of both endocrine and exocrine functions. And our focus today will be entirely on endocrine functions, starting with the 1 to 2 million islets in each pancreas, in the human pancreas. And so these islets are composed of multiple different cell types, each secreting polypeptide hormones. Alpha cells secrete glucagon, which stimulate glucose production from the liver, and this leads to an increase in blood glucose. On the other hand, beta cells that are shown up here on the right secrete insulin, and this moves glucose intracellularly, where cells can then access it as a fuel source. And this ultimately leads to a decrease in blood glucose. So this slide shows the difference in functional beta cell mass between type 1 and type 2 diabetes. In type 1 diabetes, individuals who have a genetic or environmental predisposition for type 1 diabetes, they may experience some sort of triggering event that induces an autoimmune attack on pancreatic islets. And this leads to a relatively rapid decline in functional beta cell mass and then consequently in insulin production. So they need insulin right from the get-go. In contrast, for type 2 diabetes, there are multiple different mechanisms that affect beta cells, such as inflammation, glucose, lipid toxicity. We'll look at these more in detail here in a minute. But there's also a variety of different compensatory mechanisms that mean that declines in beta cell mass and function happen later in the disease process. And because these declines occur more slowly, affected individuals are relatively asymptomatic upon diagnosis. And so that means, like, historically, upon diagnosis of type 2, there may have been very little beta cell function remaining, which meant the earlier need for insulin therapy. And in this somewhat antiquated view of diabetes, by the time someone with type 2 diabetes required insulin, they were already well into the disease process and may already be experiencing complications. And so this has kind of led to a stigma about using insulin, that it somehow signals an end stage for diabetes. However, we're screening for and diagnosing diabetes earlier now. And so what this means clinically is that, particularly in early states, if we can target some of the mechanisms that lead to beta cell dysfunction, particularly glucose toxicity and lipid toxicity, we then have the opportunity to preserve beta cell function, and this actually makes diabetes remission feasible. So this is what's known as the egregious 11, or the beta cell-centric model of the 11 different pathways that contribute to hyperglycemia in type 2 diabetes. This looks daunting. We're not going to go through this in huge detail, but what I did want to highlight is some of the pathways that are shown in blue, like immune dysregulation and inflammation, directly contribute to beta cell dysfunction, while other pathways shown in green result from beta cell dysfunction. And so ultimately, what this means is beta cell dysfunction results in hyperglycemia because beta cells are not able to secrete sufficient insulin to meet the physiological needs of that individual. And so the factors that contribute to hyperglycemia, however, they may vary from individual to individual, and it may actually change within an individual's lifetime. And so the important thing about this is that each driver of hyperglycemia presents a unique opportunity to apply targeted therapy. Now, I don't think we're quite at the stage of personalized medicine to diagnose a specific defect within an individual person, at least not to any sort of scalable model right now. However, looking at this does show why so many of the newer medications, particularly the GLP-1 receptor agonists, shows why they're so much more effective as they target multiple different pathways and defects that lead to hyperglycemia and type 2 diabetes. In addition, they also have these pleiotropic effects that lead to cardiorenal disease risk reduction as well. And so, because that these newer medications have been so effective, not only in terms of glucose lowering, but also as well as cardiorenal risk reduction, this has really led to a dramatic shift in clinical practice guidelines in our lifetime, away from this glucose-centric model of diabetes care to more of a cardiorenal-centric model of diabetes care. Let's turn our attention though back to insulin and what does insulin actually do? So I tell my patients that insulin is like the key that unlocks the door to a cell to allow glucose into it to actually act as fuel. And so without this key, there's glucose, but it's not accessible to the cell. So, in someone without diabetes, insulin is secreted in varying amounts, which has kind of led to our differentiation of different types of insulin, i.e., basal and prandial or bolus insulin. So, basal insulin is the insulin that's secreted overnight and in between meals in smaller amounts. Because it's secreted in smaller amounts, it acts mostly on those insulin sensitive tissues, such as liver and adipose tissue. Prandial insulin or bolus insulin, on the other hand, is secreted more robustly in response to a meal, and this results in higher plasma insulin levels. As a result, it acts on skeletal muscle as well for glucose uptake. And so, as a result, the end result of insulin secretion is glucose uptake by primarily three different organs: liver, adipose tissue, and skeletal muscle. And I wanted to highlight that insulin is by far and away the most effective medication to lower blood glucose in a rapid format. So, which persons with diabetes need to be on insulin? Well, that kind of depends on the type of diabetes that they have. So, this chart on the left depicts our traditional classification system for diabetes in a much abbreviated form. Of these, we know that certain types, especially type 1 diabetes, will definitely require insulin. And that's just because of the pathogenesis of type 1 diabetes. However, we've known that this classification system isn't perfect. It doesn't always match what we see in clinic. And so there's not this clear differentiation between type 1 and type 2 diabetes. And we see a lot of overlap between the different conditions. Historically, these syndromes that overlap may have been called things like type 1.5 diabetes, and now we refer to them as latent autoimmune diabetes of adults, or LADA, and ketosis prone diabetes, or KPD. And unlike type 1 diabetes, where there's much more clear biomarkers and a clear clinical presentation, type 2 diabetes is much more heterogeneous. And so multiple different classification systems have attempted to subtype type 2 diabetes. The most replicable classification system is the one shown here. And this is based on classifying based on phenotypic characteristics, disease progression, drug response, and risk of diabetes complications. So these subtypes in this classification system include the severe insulin deficient diabetes, or SID group, shown up at the top. These are phenotypically very similar to those with type 1 diabetes, but they're antibody negative, but they have a high risk of retinopathy and neuropathy. The second classification is severe insulin resistant diabetes, or SIRD, and these are characterized by high BMI and severe insulin resistance. These individuals may have a higher risk of end stage renal disease and metabolic associated liver disease. And then the bottom two are mild obesity related diabetes, who develop diabetes early in life, and mild age related diabetes, who develop diabetes later in life. And these have a lower risk of complications. So these subtypes have been reproducible in multiple different populations and may pave the way for more of the personalized diabetes approaches in the future. But let's bring it back to the present with the available information that we have about patients right now and their diabetes type and their clinical features and their clinical presentation. How do we decide who needs insulin? So, as mentioned previously, one way is to focus on the guidelines, which have shifted from this glucocentric approach to more of a cardiorenal risk reduction approach. And so, this is an algorithm from the most recent American Diabetes Association type 2 treatment guideline that has this nice algorithm that says that we should first focus on cardiorenal risk reduction, meds, and obesity indications. Specifically for medications like GLP-1 receptor agonists and SGLT2 inhibitors, because they're at the forefront of cardiorenal risk reduction and weight loss. And you'll notice that in these algorithm, insulin is not actually introduced until much later, and this is only if additional glycemic lowering is needed. We have typically started with basal insulin because it's been found to have less hypoglycemia and less weight gain associated with it than starting on prandial insulin. So that's typically been our approach, is to start on basal over bolus insulin. So this was a study of nearly 120,000 individuals with type 2 diabetes that showed that glycemic trajectories are established relatively early in the disease. And this is important because if we need additional glycemic lowering, we'll probably know about it earlier. So in this study, the investigators used insurance claims data to evaluate A1C trajectories of newly diagnosed individuals with type 2 diabetes. And they found these four distinct trajectories shown here in the graph on the left. Fortunately, approximately 70% of individuals with type 2 diabetes will end up meeting glycemic targets early on. However, nearly 30% shown here in the green lines and the blue lines, they're still struggling at 3 years. So what this tells us is early in the disease course, you'll have an idea of whether or not a given patient may end up needing more intensive therapies to help with their glycemic control, such as insulin. So in addition to those not meeting glycemic targets, there are other clinical scenarios where insulin therapy is preferred. So the first is any sort of metabolic emergency, such as um, hyperglycemic hyperosmolar syndrome, or HHS, or diabetic ketoacidosis. We need to get the glucose better right away because they're sick, right? So that makes sense. We use insulin in those cases. The second is a little more challenging. This is based on patient preference. Basal insulin in particular is very well tolerated, so may have fewer side effects, and this may be one of the reasons why patients prefer to stay on it. And then cost is another reason. So you may need multiple non-insulin therapies to get the blood sugars and the A1C in an effective range. Um, Whereas insulin is much more effective than any one agent. So if they're looking at improving glycemic control, they may get more bang for their buck with insulin. And that may be important to them if they're paying multiple copays. The third reason is based on safety in the setting of other comorbidities. This is particularly renal and hepatic comorbidities. And the fourth reason is pregnancy. As mentioned previously, any indication of type 1 diabetes or LADA is another scenario where insulin is needed based on their pathophysiological needs. And then how do you differentiate then type 2 diabetes from LADA? So there's multiple different algorithms. This is one such algorithm from the consensus statement between the American Diabetes Association and the European Association for the Study of Diabetes, or EASD. And they basically provide an algorithm that's based on antibody positivity and C-peptide levels to say, are you going to treat more as a type 1 or type 2, or more as a more as a LADA patient, right? Any scenario where concern for additional weight loss with weight loss promoting or weight neutral medications like GLP-1 receptor agonists or SGLT2 inhibitors may be another scenario where insulin is actually preferred because it's anabolic and does promote weight gain. Um, and then I kind of alluded to this previously. An additional scenario is those with new onset diabetes with really high blood sugars, where we have an opportunity to target glucose toxicity to allow for better beta cell function in the long run. So insulin may be started, but it may actually only be temporary as the beta cells are recovering from the glucose toxicity. And then, of course, per the ADA guidelines, anyone not meeting glycemic targets may also be an insulin candidate as well. So this is a summary of the major effects of basal insulin, GLP-1 receptor agonists, and SGLT2 inhibitors individually and in combination. And this highlights that combining insulin with GLP-1 receptor agonists or SGLT2 inhibitors not only ensures cardiorenal risk reduction as well as better glycemic control overall, but it also helps to attenuate some of the two main adverse side effects of insulin, which are namely hypoglycemia and weight gain. And so by combining an SGLT2 inhibitor or a GLP-1 receptor agonist with insulin, you minimize the side effects of insulin. You minimize the weight gain and you minimize the hypoglycemia. And so our goal is to really say if anyone's going to be on insulin, as much as possible, trying to get them on a GLP-1 receptor agonist or an SGLT2 inhibitor as well may help to attenuate some of these side effects. So with that, I'll turn it over to Jenny to talk more about actually how to use insulin.
All right, and we're gonna pull a little switcheroo here with the slides. So let me replace current slide share, and I will take over from here. Can you see my slides? Let me get it in slideshare.
Yeah, we can see them.
Perfect. All right. So thank you so much, Dr. Mizukami, for going through all that pathophysiology and a lot of the data underlying the reasons and indications for insulin. I get the fun job of then the nuts and bolts of like, how do we actually do this in practice? So I'm going to start by just kind of going over some of the practicalities of creating an insulin regimen, and then we'll talk about how to counsel your patient when you start them on insulin. And the first thing I want to say is I think a little bit why insulin can be intimidating is because there's so many different types of insulin and there's not a really well-defined dosing range, right? You kind of have to get a feel for it. So, I can look up on UpToDate what dose of an antibiotic someone needs for a certain indication. But when it comes to insulin, you'll find really variable insulin requirements. I mean, I have patients where 1 or 2 units of insulin is the make or break between them being 400 and being 40. I also have patients who have extremely high insulin needs. I've prescribed as much as 900 units of insulin a day for my outpatients. So it's a big range, lots of different insulin types. And I think sometimes that can make it a little bit intimidating to want to start someone on insulin. The beautiful part about insulin, though, is you really only need to understand the speed of someone's insulin to understand how to interchange them and how to use them. Because as a rule of thumb, a unit of insulin is a unit of insulin is a unit of insulin. So you can see here we have all these rapid acting insulins, we have our long acting insulins, we have ultra long acting insulins. But at the end of the day, what it comes down to is that a unit of insulin is equal to any other unit of insulin. What changes is how fast they work and how long they work. And so the reason why 10 units of Lantus is a fairly small, mild dose of insulin, right? Is because that 10 units is spread, as you can see in this graph, over 24 hours. Now you give someone 10 units of aspart, all of a sudden that 10 units is only spread over a couple of hours, and you can see how quick, that insulin takes effect. And so that's why 10 units of aspart might drop someone low, and 10 units of Lantus, you're probably not going to like immediately notice an impact, right? But we can still use the fact that these interchange when we're designing our regimens, when we're thinking about insulin resistance, when we're thinking about total daily dose, which is how we often think about insulin. That's the sum of all the different insulins that someone's taking in a day. And that can help us craft a regimen. And we're actually going to do a case soon here that's going to go through some of that. Yes. And so then just to make things more confusing, right? On top of the fact that we already have all these different insulins and all these different speeds, this is actually kind of new when I was coming into practice, is we started to get U200 insulin and U300 insulin, just to like throw a little loop into things. So I just wanted to make a quick note on these concentrated insulins. The concentrated insulins work like any other insulin. They exchange one for one. So U200, which is going to be your Tresiba, or U300, which is going to be your Toujeo, will interchange evenly with a Lantus or a glargine pen. So if someone's on 50 units of Tresiba, I can equally just convert them to 50 of Lantus. If they're on 50 of Toujeo, I can also convert them to 50 of Lantus. Don't try to do anything fancy. Don't try to like multiply by 2 or halve it or triple it or anything like that, because these are always administered in pens. And so basically they dial in that dose. And if it's a U200 product, it's going to deliver the same number of units. It's just delivering half the volume. And same for that U300 pen. An advantage of these pens, right, is a standard pen usually only goes up to 80. If we're talking about a 70-30 pen, it only goes up to 60 at a time, right? So sometimes when we have patients who have these bigger dosages, they don't want to have to inject twice to get the dose that they need. So a U200 Tresiba is going to allow you to go to 160 units. The U300 Toujeo Max is also going to allow you to go to 160 units. Just be careful you prescribe the Max pen, right? Because there is a Toujeo pen that just is a standard pen that's only going to go up to the 80. Now, U500, however, is a whole different beast. And so unless you have a lot of experience working with U500 and you've been trained in how to use U500, I would not try to craft a U500 regimen. That's something that kind of takes some time and takes some feel for it, and it is a high-risk medication. Now, it's still true that a unit of insulin is a unit of insulin, but U500 has some really weird kinetics. It kind of has a peak, and then it's got a super long tail, so it acts as both a basal and bolus insulin. So it's definitely one of the hardest ones to interchange for other insulins. And usually, frankly, when I'm converting someone from like a U100 or U200 regimen into a U500 regimen, I'm looking it up on the Lilly website, and I'm just going off of the algorithm that's suggested by the manufacturer so that I know that I'm doing something safe and that I'm following the recommendations. So imagine now, we talked about how there's this like beta cell dysfunction. So I want you to imagine for a minute that someone makes like no insulin at all. How would we sort of mimic the body and create what their body needs, right? So this like basal bolus insulin has become the gold standard, like classic regimen for prescribing insulin. And what it means is we're giving a dose of basal insulin to cover those like that constant need that we have for insulin. Dr. Mizukami Stout alluded for. Your body's making sugars all the time. It's making sugars through gluconeogenesis and glycogenolysis in the liver. I get a lot of patients all the time who are confused. They're like, I went to bed and my sugar was 150 and I woke up and my sugar's 210. How is that possible? I didn't eat anything. And I'm like, well, of course. Your blood sugar doesn't fall to 0 when you're fasting. It doesn't just like trickle off to nothing. Your body needs sugars all the time. Most importantly, the brain needs sugar in order to function. And so your body's going to be generating sugars, whether you're eating or not, to help feed the body. And so if you don't have insulin in your system to make up for those sugars that are being generated, sure, your sugar can of course rise even when you're fasting. So we get that shot of long acting traditionally at night. That's going to help manage the basal needs. But then you get these bursts of insulin. You need bursts of insulin when you're eating. And you can see that we're not quite as good as the body. So when you look there, like the shadow is showing you what like the normal insulin profile would be for someone who can make insulin. You can see how rapid and how sharp the body is in response to food. We aren't quite that good. Even our short-acting insulins, they're short-acting, they're not instantaneous. It still takes 3 to 4 hours for them to finish working. But we do our best to try to replicate that pattern of insulin, having some all the time, but these bursts of food with our basal bolus pattern. But as Dr. Mizukami said, most folks with type 2, you're not actually going to start them on a basal bolus regimen. What you'll probably be more familiar with is a basal only, or what I call like a basal plus type regimen. And so what we mean by that is like basal only would mean like strictly basal insulin. Basal plus is referring to the fact that we often can use like these agents that we like to use anyways, SGLT2s, GLP-1s, these can often help us with our prandial sugars. So the way I explain it to my patients, because they're often wondering, okay, well, I'm starting on insulin. Does that mean I stop my SGLT2? Does that mean I stop my GLP-1? And I explain to them that like, no, not necessarily. We still want the cardiorenal benefits, but also those are, we're depending, because we're only giving you basal insulin, we're depending on your body to still make insulin for you when you eat. And that GLP-1 medication that's going to slow food from the stomach to the intestine, that's going to make it easy for your body to try to generate that insulin to try to match that peak, right? And likewise, SGLT2s, they don't do much for you when your sugar's low, right? They adjust the glucose threshold. So if your sugar's low, SGLT2 isn't doing much. You have a high carb meal, sugar shoots up. Now that SGLT2 is working for you. So these are great, GLP-1s and SGLT2s actually pair really nicely with basal insulin. And then, of course, we always still are going to want to use metformin. Metformin's our cornerstone of therapy. So if it's tolerated, I remind them that like your body's still making insulin, and I want to make you as insulin sensitive as I can, so that your body can still try to generate that insulin for meals. That's going to help us avoid needing mealtime insulin injections. So if I'm starting someone on basal only, I usually will start about 0.1, 0.2 units per kilo per day. If you want to make it easy, just a flat 10 is easy to start. It's probably on the low side of an estimate, right? But the beautiful part about outpatient is we have time. So I give them like a handout. I tell them like, go up by 2 units or by 4 units every 3 days based on your fasting blood sugar. Sometimes I'll even have thresholds like if your sugar's over 250 for 3 days in a row, go up by 4 units. If it's over 150 for 3 days in a row, go up by 2 units. And then I usually give them a max. So I usually set like, don't go above 0.5 units per kilo. And I'll give them what that amount is unless you talk to us. But we have that time and that luxury in the outpatient setting where you don't have to like start them on a full 0.4, 0.5 a day, right? You can start them low, work their way up. And I just tell them, we got to find your magic number. I don't know if your magic number is going to be 18 units a day or 25 units a day or 57 units a day, but we need to find that magic number that gets your fasting sugar to goal. And then, some of our type 2s will need basal bolus insulin. If you're doing basal bolus insulin, it's generally going to be folks who have somewhat higher requirements. 0.4, 0.5 units per kilo a day might be a place to start. So someone comes with extremely high A1C, or like we talked about those like glucotoxic situations, someone's hospitalized for hypoglycemia, it is possible we might want to start basal bolus out the gate. We'll probably start higher. The magic ratio for that is going to be 50% basal and 50% bolus. And so what I mean by that is, someone's using Lantus 24 units a day. The equivalent Humalog would be 8 units 3 times per day. So that would be 8, 8, 8 is 24, and that would, get you balanced regimen. And again, we'd still want to potentially continue non-insulin agents if there's a cardiorenal benefit. So let's do a case to kind of illustrate what we're talking about and how to convert regimens. So Mr. Johnson's a 58-year-old man. He has type 2 diabetes and he presents for follow-up. Right now, he's taking U200 Tresiba at a dose of 110 units once per day. He's on metformin, Ozempic, Jardiance. His most recent A1C is 9.1, despite good adherence. He checks his blood sugar once per day in the morning. His readings are typically 90 to 130. He has no significant hypoglycemia. When you look at the logs, you can see that his fasting sugars are controlled. He's not consistently maybe checking his sugars later in the day, but when you do, they're generally high. So the question would be, what do we do next to improve his diabetes management? And so the key factors from this case are that his fasting glucose is actually fine. So it tells me that increasing his basal insulin further will probably not fix his A1C. You don't really have room. You don't want to make him low in the morning, right? So probably the issue here is probably that he has postprandial hyperglycemia. And that's really what's driving up his A1C. And if you could stick a CGM on Mr. Johnson, you might see something like this. So this is one of my patients who is on a basal heavy regimen. So remember, he's on 110 units of basal a day and like no bolus insulin. And the basal really should just help keep the sugars flat overnight. But sometimes we escalate, and they end up on this big dose of basal insulin that really is like dragging them down overnight. And then during the day, they're eating. So they're still going high because they're not really keeping up. They're not able to generate enough insulin to keep up with their prandial needs. And so they kind of run high throughout the day. And then they do this where they fall again overnight. And so when we see a basal heavy regimen, we want to rebalance things. We want to get that basal back down to like a true basal, just keeping them flat. We want to use meal insulin to try to target those prandial highs. And so the next step, what I would do in this case is I would reduce his basal insulin to avoid over basalization. Keep in mind, like in that CGM I was showing you, the patient was pretty high. So there's probably not a lot of hypoglycemia, and there wasn't a lot of hypoglycemia reported by this patient. But sometimes, like if they're NPO, they're going to drop. If they don't eat, if they skip a meal, they're going to drop. And sometimes that actually trains our patients that they have to eat to keep up with their insulin. And we never want to be putting our patients on an insulin dose where they feel like they have to eat more or eat to keep up with that insulin. So in this situation, it's better to drop that basal dose, introduce some mealtime insulin for better after meal control. Now, you always can optimize diet, and that's always a choice, right? So if someone actually is like pretty good control and you're just noticing spikes, like I had someone who I saw in my clinic recently, and he actually was doing like a protein shake for breakfast, he was doing like a salad for lunch, but dinner, that was his meal where he sometimes ate out, and he just like, I could see it just clear as day on a CGM. Dinner was like the one time that he was running high. So in that particular situation, I actually just counseled him on like lowering his carbohydrate intake with dinner. But sometimes I also think we sort of fall in this trap where, I'll tell patients like, okay, you gotta like, we need to control the prandial sugars. And they say, yeah, I'll like lower my carbohydrates a little. I'll cut out on the sweets after dinner, something like that. And, in this particular scenario with this patient that I'm showing you, his A1C is quite high. So it's not something like just cutting out sweets after dinner is probably going to be enough to get him to target. You would really want like a bigger commitment to dietary changes if you're really expecting to see like what we like 2-point drop in their A1C, right? So sometimes I have to have like a little bit of a realistic conversation with like, do you really think you can make enough of a change in your diet to drop your A1C from a 9.1 to a 7.0? If they feel like they can't do that, then we might be kind of going back to the question of insulin. But again, we always want to be thinking about diet on top of adding, potentially adding insulin therapy. So what would I have done in this scenario? So again, if you ask 10 different endocrinologists about insulin dosing, you will get 11 different answers, but this is what I would do. So, if I saw this person who's on 110 units a day, and if they were willing to balance out their regimen by adding a mealtime insulin, I'd probably reduce their Tresiba somewhere to like 55 or 60, and then I would add meal coverage 10 or 20 per day. How did I come up with that? Well, one, it's like I'm trying to balance it, right? But two, I kept the total daily dose about the same, right? So if you do 60 units of Tresiba, and you did 10 3 times a day Humalog, you'd be at 90. If you did 23 times a day, you'd be at 120. So I kept the total daily dose roughly the same, but maybe like, especially since he's above goal, you might make a 10% or 20% or so increase. Now I love a sliding scale. So the other option is sometimes I play it a little bit soft on the Humalog coverage, but I add that scale and that can make up the difference. So I might choose 12 or 14 a Humalog, but if I'm using a 4 per 50 greater than 150 for their scale, then I know that like if they are running a bit high, even though I'm telling them to take 12 or 14, they're probably going to be taking 16 or 18 or even 22 based on the scale. So that scale gives me a little bit of give, so I can be a little more conservative with the base doses, but still know that I'm going to get them down to target. So the take-home message here, though, is that when fasting sugars are good, but the A1C remains high, it's time to add bolus. Don't just keep cranking up the basal, because you'll get them into that bad cycle of eating to keep up with the insulin, and they're still going to run high during the day, and they're just going to be dropping overnight. Let's go to a somewhat different scenario here, right? So Miss Smith is a 64-year-old. She was diagnosed with type 2 diabetes 8 years ago. She's on metformin, GLP-1, SGLT2. She has relatively good adherence, but her A1C remains high at 9.1. But she is sometimes skipping her GLP-1. She's getting nausea and stomach upset with her GLP-1. There's really no room to go up on that. And her home glucose readings are anywhere from 190 to 250. She's motivated to improve her control, but she's been frustrated that her oral medications are not enough. And again, like things that I'm thinking about here is like, she's already on 3 agents, right? Her A1C is quite above target, like close to about 3 percentage points above target. So we're not like, it's not that we're just tweaking things just to try to get it down a hair, but we have like a substantial amount of improvement that we need to make. And then we may be, limited again. So it's like, we can't just go up on the existing agents that we have. And so the keys from this case are that we have inadequate glycemic control on maximized non-insulin therapies. We have maybe some intolerance that might limit escalation. And, a lot of the patients are frustrated. They're like, I'm already taking 3 things. And every time I come to see you, you're telling me I'm not at goal. And so, I'll have this conversation. I'll say, well, I can add a 4th agent, right? We could add a sulfonylurea. I could add pioglitazone here. I could add both. But we know that on average, an oral agent or non-insulin agent, most of the time, statistically speaking, you're getting down like a point, maybe a point and a half. When you're talking like DPP4s, which I like wouldn't use in this case because it's combo with a GLP-1, but DPP4s, you're really talking like sometimes like a 0.5% of A1C lowering, right? So I could add one or even 2 agents and we still may not get her to goal. And then she'd be on 5 agents. And so sometimes I like kind of balance. I say, well, put you on insulin. I'm really confident I could get you to target. Or if you want to try a non-insulin agent, I'm game, but we still may not be there. And then you're on 4 agents and we're still not necessarily at our glycemic goal, right? So in this situation, if the patient's willing, after discussing the risks and benefits, you might want to start basal insulin. And again, this is a situation where you could start 10 once per day. You could do 0.1, 0.2 units per kilo, and then just titrate up slowly. But one of the reasons why I had to bring up this case is this is someone who's insulin naive, right? And so this would be a situation where you're starting someone on insulin who's never been on insulin before, and you really have to have your spiel ready, right? So we all have to have that like really quick spiel of like, there's so much to tell a patient who's being started on insulin. And you want to make sure they have all the information to leave your office and start insulin that day safely. And so it's a little bit of a muscle that you kind of have to build. Like, what do I need to tell the patients? What are the key points? How do I not like overwhelm them? And so I'll kind of go through briefly what my like spiel. So our last objective here, what do I tell patients when I'm starting them on insulin therapy? So here are the key counseling points. I talk about where and how to inject. I talk about timing. I talk about insulin storage. I talk about treating low sugars. And I talk about when to call the office. And so where do we inject our insulin? I always tell the patients, and I stole this from Dr. Kumagai, who was a professor at U of M when I was training, but he used to tell, or I heard him tell one of his patients, above the knees, below the clavicle, avoid the belly button, and you can't go wrong. And so I often will just repeat that to my patients, right? I let them know that we want to inject insulin into the subcutaneous fat layer. I tell them, don't do anything fancy. Don't try to get it into a muscle. Don't try to get it into a blood vessel. We all have that little sub-Q fat layer under our skin. You just want to inject this into fat tissue, okay? Don't try to get it anywhere else. And don't keep poking yourself at the same spot over and over. If you poke it at the same spot over and over, it's going to get lumpy. It's going to get hard. So just make sure you're using all your real estate. You can use anywhere where you have that subcutaneous fat, right? And you can inject. So favorite spots are obviously going to be the abdomen. Upper arms are fair game. Upper outer thighs are fair game too. So those are going to be the most popular injection sites. Then I talked to them about timing. So long-acting insulin traditionally is taken at night, but I really don't care when they take it as long as they remember to take it. And they should be taken about the same time every day. So nighttime's usually fairly simple, but I have some folks where depending on their day, sometimes they fall asleep, they forget to take it. And so they might be better candidates to take it in the morning. And the thing that I always remind them is that the long-acting insulin should just march out. We should just keep taking that long-acting insulin at the same time of day, every day, just steady Eddie on that insulin. A lot of patients, you'd be surprised the number of times someone tells me, well, I take insulin they take their rapid acting with dinner. And well, on Saturday night, I didn't take my long-acting insulin because we had dinner late. I didn't eat till 9 o'clock. I normally take my long-acting insulin at 10. So I thought I couldn't take my short and my long that close together. And I'm like, no. We just always take that long-acting insulin. We just march that one out. Now your short-acting insulin, that's paired with the meal. The meal and the short-acting insulin are buddies. So we only take that short-acting insulin if we're having a meal. If we're not having a meal, we do not take that short-acting insulin. And we will take those two together, right? So, weekend, you decide to have late brunch, that insulin's going to be later. Normal work day, you get up bright and early, you're going to have that insulin early. So marry that one in your brain to the meal. It is best if they can take it 20 minutes before a meal. I don't always know 20 minutes before I'm going to have a meal. So if the time that they can remember is right at the start of a meal, that's totally fine. Sometimes I use the phrase check, insulin, eat, right? So if they're still doing finger pokes and not using a CGM, they would check their sugar, take their insulin, take their first bite of their food. If they forget, they can take it late. If it's going to be more than like 30 or 60 minutes late, I tell them just forget it, take it then at your next meal. And again, I often have people on scale. So they'll probably they forget breakfast coverage and they go to lunch and they're a little high, right? They'll just take a little bit of extra on their scale to compensate for that. Storage. Insulin pens or vials should be kept in the refrigerator if they're unopened. Unopened insulin is good until its expiration date, so that goes off the package. I can't tell the patient how long that's good for. I tell them they have to read the label. If it's open though, it should only be at room temperature for max of 28 days. There's a little bit of variability in this with the manufacturer. So if you really want to get picky, you can look at the manufacturer website for each one, but most of them it's around a month. And then after 28 days, it should be discarded if it's not fully used. So this most often is going to happen with like rapid acting insulin, particularly for people who are only on sliding scale. But rarely I'll have someone who's on long acting insulin at a small enough dose where they're going to have to remember to throw that out once a month. And sometimes we have to make sure to remind the pharmacist of that, particularly if they're on vials, right? Because sometimes 2 vials would like theoretically make it 90 days. But I'm like, no. They need a vial every month at minimum because they need to throw it out when it's open at the end of 28 days. Insulin should never be frozen, right? It denatures it. Don't store it in your car. Like a lot of people want to carry it in their purse, but then they'll like leave their purse in the car, or they'll keep it in their backpack. They'll leave their backpack someplace. Like, so in the car in Michigan, our temperatures are too variable. It's going to get hot. It's going to get cold. So just keep it, at room temperature. Next part of my spiel is I always tell people about low sugars. So we have the 15-15 rule. What that means is you treat a low with 15 grams of carbs, you recheck in 15 minutes. We use simple carbs. There was this like old school idea that we used to give people like peanut butter crackers is how you treat a low sugar. That was from the old days of older insulins where you actually like, you're kind of treating the low, but you're also worried that they're going to get low later on. So you're kind of trying to give them a carb and maybe like a protein or something like that to sustain them. But these days we usually just want something simple just to pull it up. If they're doing like Snickers bars, I mean, it will work, but it's going to be slower than if they just had like, a Lifesaver or a Skittle or something that's just a pure sugar, right? But the biggest thing is not to overtreat. People always overestimate how much it's going to take to bring up a sugar. 15 grams of carbs is not much. So, I put some examples of 15 grams of carbs there. The big one is pop. People want to drink a regular pop to treat a low. And I always tell them it's a third of a can of a regular pop to treat a low, not the full can. If you do the full can, you're going to be 200, 300. Oddly, the opposite, glucose tabs, people somehow want to underutilize those. So glucose tabs are great. I tell people buy glucose tabs. They don't expire. You can put them in like your nightstand. You can put them in your car glove box, like have them handy. And like, you should always, right, have something in your car, right? Because if someone's on insulin, I don't want them driving with a low sugar. You should always check their sugar before they drive. They should always keep some kind of sweet, rapid acting carb in the car. But people always want to do like 1 glucose tab. And I'm like, no, a glucose tab is just 4 grams of carbs. So they're going to need usually 3 or 4 glucose tabs to treat a low. And so just remind them of that if they're using their glucose tabs. Because sometimes people pop 1 and they're like, it didn't do it. I had to keep giving myself them. And I'm like, yeah, it's like, because the serving size is 4. I also generally, for my folks on insulin, will prescribe glucagon. The trick with glucagon is just remind your patients the glucagon is not for them to give themselves. Like, if you are awake enough to go get yourself some sugar, you will feel better faster if you treat yourself with simple carbohydrates or sugars than you will feel after you give yourself glucagon. Glucagon doesn't always feel good. It makes people nauseous. Very effective, brings sugars up. Like, I mean, it's very good at bringing up blood sugars, but you're going to feel better sooner if you treat yourself your low with just something sweet. You also have to remember that glucagon is telling the body to like dump sugar from the liver. So it's very effective, but then you have to like eat again to recharge the liver. You can't be like dosing glucagon back to back. If you're not eating in between, it's not going to work the second time around. We used to have those old school red boxes. Now we have Gvoke, which is an EpiPen style. We have Baqsimi, which is the nasal spray. I'm going to be honest, I prescribe a little more Gvoke than the Baqsimi, although I do both. But I've had a lot of complaints about the Baqsimi being kind of forceful and giving people headaches. Like, it's the nasal squirt. And I think if anything, I'd be worried it wasn't like going up there enough. But people tell me it's like it packs a punch. And so I've been going with the Gvoke a little bit more. But, either one is fine. And then finally, when to call. I tell people to check in with us 1 to 2 weeks after starting insulin, just so we can see where they're at. If I'm giving them that basal titration, I'll typically set a max dose, 0.5 units per kilo, that they shouldn't exceed without calling. If they have a sugar that's under 70, treat the low first, then call us. If they call us with a sugar under 70, that's a red call, and it has to get paged out to the nurse. We want them to treat the low and get their sugar up to a safe range. Then they can be on the phone with us. So I always tell them treat first, then call. Obviously, if they're having a hard time getting it up after they've already done the usual like 15 grams of carbs and recheck in 15 minutes, then they're welcome to call for further advice. But it's best if they can to just get that sugar up, and then then we can kind of troubleshoot after the fact as to what happened. And then if the sugar's over 350 twice in a row, call the office. And that's again because often I'm titrating up the insulin, so I do sort of expect the first couple of days it's going to take a little time for those sugars to come down. But 350 over 350 twice in a row, that also prevents you from getting calls. Sometimes I would get calls that were like, I ate an ice cream sundae after lunch today, and when I checked at dinner time, it was high. And I'm like, okay, like take your insulin and your scale for dinner, and you should be back down to normal. Like it should be fine. So just to avoid the frequency of calls, if it's high twice, then it's usually not just some like random dietary thing, right? So I usually go off of the sort of 2 strikes you're out rule. All right. And then finally, we just remind patients that starting insulin can be life-changing, but it doesn't have to be overwhelming. I think a lot of patients have a lot of preconceived notions about insulin and what it means to start insulin. And does this mean they're going to be on insulin forever? So just remind them that like starting insulin isn't a sign that they necessarily failed. Oftentimes in our practice, we're seeing a lot of these like LADA patients or these patients with like insulin deficiency. And so it's a therapy like anything else. It's not a punishment. It's not something that we're doing because they haven't been good at controlling their diabetes or they're not trying hard enough, right? So just make sure you're reassuring your patients, that we're here to help and we're here to optimize their diabetes regimen, but we're not here to be judgmental or, provide value judgments about certain therapies versus other therapies. And with that, we did save one slide at the end about insulin pumps, which I think, Dr. Mizukami, do you want to like pop on here, or do you want to just see if anyone has questions about insulin pumps? Like, because we could always, if there were questions in the chat or something, we could do that too.
Yeah, I just wanted to highlight on this one that it's can you hear me okay? Sorry. That there are insulin is a pain to take. There's no question about it. It's a pain to take. It's a different lifestyle. But there are things that specifically that we do in endocrine that we can really help with insulin delivery modalities. And so we often get referrals for this person needs a pump. Maybe it's not a pump that they need, but maybe they do need a different sort of insulin delivery device. And so this is just a slide with some of the newest like insulin delivery modalities available. So we have smart pens that help to calculate a dose of insulin. They help to remind a patient that they need to take their prandial insulin. It also records the amount of insulin that they're taking, which is a really nice feature if you're like, how much is this person actually taking? We have patch pumps, which are disposable, either that deliver basal insulin and bolus insulin, or they only do bolus insulin. And then all the way on the right here, we have these automated insulin delivery systems that we're typically thinking about for type 1 diabetes, though more and more are being approved for type 2 diabetes, and specifically the Omnipod 5. Those are not typically our first resort, but in some individuals who are just really struggling, it may be a good option temporarily or, going forward.
And then here are some resources about insulin, and we are actually hoping as a collaborative, we're going to get some additional handouts on the MCT2D website and some new like kind of resources for like sort of starting insulin toolkit kind of thing. So be on the lookout for those. I think we're hoping to get those up by the end of the summer. And then there's questions in the chat. So Jackie, do you want to moderate, or should I just take a look at what's in here?
Yeah, I'm happy to. There's a lot of comments. I think one of them's been answered around what was the source for the LADA versus type 2 diabetes algorithm. So Dr. Ang responded to that in the chat. We will share the slides. And then otherwise, right now, a lot of the comments are just saying, it was a great talk, wonderful presentation. But if anyone has any additional questions, please feel free to either unmute and ask, or you can put them in the chat, whatever you're more comfortable with.
And I'll just start off by saying on that algorithm for LADA versus type 2, just be super careful on the units, right? Because that's a European guideline. It took me a hot minute to figure out that the like units that like U of M reports for C-peptide are a totally different set of units than what the Europeans use.
I put that in the chat because I've been fooled by that too. I've totally been fooled by that too. It looks like we have one question here. Do you still feel that metformin is warranted while using other agents for increased insulin sensitivity? And what are your thoughts on pioglitazone? Jenny, go for it.
Yeah, I still think metformin is a cornerstone. I think if anything, like cost-wise, right, metformin's very effective. Metformin's also very well tolerated. I mean, I always say you can thread that needle with the GLP-1 where occasionally I get a patient who like feels great on it. They have no GI side effects. They get awesome weight loss. You know, we all have those like wonderful success stories with the GLP-1. But I also get a lot of folks who get nausea, constipation, diarrhea, like every GI side effect under the sun. So just in terms of tolerability and cost, I still love metformin. I consider it very like low risk medication. I know we always talk about like kidney injury and adjusting for renal and lactic acidosis, but frankly, if you just keep a good eye on the GFR, we don't run into issues. Pioglitazone's interesting, right? Because there's this whole backstory of like rosiglitazone sort of getting blamed for maybe some things that weren't its fault and then being exonerated, but like basically it fell out of favor after some articles. And, you know, but pioglitazone is still around and having kind of this resurgence in the setting of MASLD, right? I use it sometimes. I will say the water retention and the weight gain with pioglitazone is real. Like I have definitely run into that. And so I still favor metformin over pioglitazone just because A, it's our tried and true. But also when I tell people that metformin might give you not a lot of weight loss, but like you might get a couple pounds. You might get like 3 or 5 pounds of weight loss with metformin, where I tell them with pio, like they're going to read that water retention and weight gain are possible side effects. And that's a real turnoff for a lot of them. So yeah, I think we're going to be prescribing pio more. For some of us, there's some endocrinologists at U of M that have long loved pioglitazone and have always been prescribing it. But I think we will see a resurgence, but I think it will be specifically tied to the MASLD folks, which, as Dr. Mizukami pointed out, is like kind of that subset that's really at risk for MASLD is going to be those with like significant insulin resistance, as opposed to some of these insulin deficient patients that may be a little less prone.
I did want to highlight too, there is a group of patients who I think about pio specifically in addition to MASLD, and those are your secondary stroke prevention patients, right? That's like there is good clinical trial data that suggests that there's secondary risk reduction in stroke patients specifically with pioglitazone. So that is often like, hey, I have a post-stroke patient, they have no other cardiovascular manifestations, then I'm thinking about pio for them as well. And like Jenny said, it's like some people respond really, really well and others don't. And that's true of any sort of indication. And I think as this era of personalized medicine goes forward, we'll have a better idea of who's going to be like the super responders for GLP-1 receptor agonists, et cetera. We don't necessarily have that now. So unfortunately, it's kind of like a have to try it and see how you do type situation. Any other questions?
Just had one more come in the chat. I am a RD studying for the CDCES exam. I have heard different things about the sliding scale. Can you speak to what you mean and how this is used?
Yeah, so people mean different. So I guess I'm being bad when I say sliding scale, right? Because we always use the term prandial, like bolus insulin carb coverage, right? We kind of like you throw out these different terms interchangeably. But really, when I'm talking slide, I'm talking correction, right? Correctional insulin, different from preventative insulin, mealtime insulin that we give people something when they eat, right? So let's say I have a patient who's on 10 of Humalog with meals. What I tell them is that 10 of Humalog is to cover the rise you're going to get when you eat. Now, if I prescribe a correctional scale on top of that, that would be extra insulin on top of the 10, which is if their pre-meal sugar is already high going into the meal, I don't just have to prevent the high that I know is coming from the food. I have to bring down the fact that they're already running high. And so a standard scale, rule of thumb, if someone's on less than 40 units of insulin per day, I will use a 2/50 greater than 150 as my scale. If we're talking someone, I take that back. If they're under 40, I'll probably do 2/50 greater than 200. If they're like 40 to 80 units a day, I'll do 2/50 greater than 150. So I'll just kind of slide that scale down. 80 or more, I think about doing 3 or 4/50. So that's that step increment, right? Like the the 4 per 50 means that every 50 points I'm going up by 4, or if it's 2 per 50, every like I'm going up by 2s. So the most important thing is like pick the right scale for their total daily dose. You know, on the inpatient side, we always say like, don't pick the high scale just because they're running high. You pick the high scale because their total daily dose is high. Someone might have really high sugars, but need a low scale. But really we separate those two. We separate what we're like, we have to be very intentional. What am I using to cover the meal versus what am I using as a correctional amount of insulin? We blend those in the outpatient setting. This is why it gets like as confusing as mud, which is a lot of times we'll write the scale and to simplify it for the patient so they don't have to think, oh, I'm going to take 10 and I'm going to add my scale. We just write a simplified scale where we'll say like, you know, if your blood sugar is less than 150, take 10. You know, if you're 151 to 200, take 12. 201 to 250, take 14. That's really a meal coverage of 10 with a scale of 2 per 50 greater than 150 on top of that. And so if a patient comes to your office and says, I'm on scale, I'm always like, we're going to have to like write this out and hash out what you're actually doing, because I need to understand, are they on a true correction only scale? Correction only scale should always start at 0 because it's only correcting you for the highs, versus is this someone who's on meal coverage where even if their sugar's normal, like 120 going into the meal, they're still taking something. So just like get the correction bit and the meal coverage bit separated in your brain. It makes things easier, but often for patient speak, we often just like crash those two together and it just becomes like just a sliding scale, right? Okay, we have someone it has been on basal, GLP-1, SGLT2, and need to add on bolus. Do you go with the total daily dose based on weight and recalculate? You know, it's hard sometimes. The weight-based dosing is like, it's real fast and loose. I find that the weight-based dosing is a good to like build your spidey sense, but what I tend to do is I tend to match my basal, you know, so I kind of do two things. First, like in that one scenario where we had someone who was on 110 estraceba, based on a weight-based dosing estimate, you could tell that that was actually like too much basal, right? Like normally someone type 2, 0.5 to 1 unit per kilo, but if someone said like more than 100 units of insulin a day, they're probably over basaled. And so in those situations, I might actually hold the total daily, pull down the basal, add in the bolus to compensate based off that, keep the total daily relatively the same. But let's say you think, like, I think in your scenario, you're kind of talking about someone who is on a true, like someone who's truly on, like they're on 40 of Lantus and I want to start meal coverage, right? I would probably just choose something that I think is going to make it balanced. So if I had someone on 40 Atlantis, I'd probably choose 10 because 10, 10, 10 is 30. They're going to be on 40 of Atlantis and then like 30 of rapid acting, and it gets them like about to that 50-50 ratio. So I just balance them out. You know, but you do have to take in that weight-based dose into consideration if you're worried that they're over basaled. The other thing you can do sometimes, right, is just add rapid acting insulin with just one meal a day. So like in that same scenario, I have someone on 40 of Lantus and I want to add meal coverage. I might add just 10 of rapid acting with dinner just to like sort of get their feet wet, right? Why do we go from 1 injection a day straight to 4 injections a day? But I would probably still, like in my brain, I'm not going to put them on like 40 once a day of Humalog in that situation. I'm still going to keep it sort of ratioed. So 10, maybe 12 with dinner, 14, something like that. Because that way I know that if I were to multiply that out across 3 meals, it would still be balanced 50-50. And sometimes you do have to take into account, like some people won't have 3 meals a day. So I might be slightly more aggressive if they're like, I have 2 big meals instead of 3 meals. I might still try to get them close to that 50-50. It might be a little hard in people on just 2 meals a day. Do I factor in the other agents? Sometimes I'll factor in other agents, particularly if I'm stopping, right? So the one that I almost always stop when I start people on mealtime insulin is going to be sulfonylureas. So sulfonylureas and people with beta cell function can pack a punch. And so sometimes if I know I'm stopping a sulfonylurea and I'm starting mealtime insulin, I might be more aggressive on the bolus insulin. But otherwise, normally I'm initiating this already when people are not controlled. So I almost like will tell the patient, like, I just want to hold everything else steady. Let's just add this mealtime insulin. You know, because it's too many moving things. Like if we're trying to like remove agents or titrate other agents at the same time, it can get a little confusing. So, but sulfonylureas are definitely one that I will stop when we add mealtime insulin. The ratios for carb to insulin, the correction doses provided to the patient. So so if you're talking about carb counting, like, you know, what's their carb ratio? Like how many units of insulin would they need for meal coverage if we're adding short-acting insulin in a carb ratio? We do that with the help of our diabetes educators. What the diabetes educators do is they'll actually have the patient keep logs of what they ate so we can understand how many carbs they're eating. And oftentimes patients are started on fixed doses before they go to the carb coverage. So they basically will see like how much is the patient taking and how many carbs are they having on average. Sometimes they'll use the total daily dose to do those calculations. Obviously, there's some rule of thumb like 450 divided by the total daily dose gives you a carb ratio, right? Like you can do that if you think your doses are pretty close. If you think their total daily dose is pretty close to right. But that's usually something that takes some training. So I normally wouldn't just like out at the bat, like in my office, start someone on a carb ratio. They'd be working with our educators. They'd be logging their food so we could like understand their relationship between their carbs and not. What I do tell my patients is I'm aiming for consistent carb diets. So I do remind them like, oh, if we're starting Humalog 10 units with meals, like if you have a steak salad one day and you have macaroni and cheese the other day, those are really different carb counts. Steak and salad has basically 0 carbs, like maybe just the croutons or the salad dressing, right? You know, a big bowl of macaroni and cheese has got all kinds of carbohydrates in it. And so I tell them like that 10 is like going to be too much when you have your steak salad, and it's going to be like not enough when you have your macaroni and cheese. So if we're doing fixed dosing of insulin, which is what we're normally talking about in our type 2s, I remind them that we want a carb consistent diet. So I tell them to pick a like low, like something that's fairly low. I don't want them eating a lot of carb. I don't want them getting a consistent habit of a high carb diet, but I'll tell them, why don't you pick like 45 grams of carbs with each meal and try to set that as your goal and try to be consistent about that. And if you're having macaroni and cheese, maybe do a half plate of macaroni and cheese with some salad or something to balance it out. You know, if you're doing that steak salad, you might need to add a bread roll or something, just like kind of keep it consistent. Do we use the 1800 rule? I use 1700. I've always used 1700 rather than 1800, but yeah, 1700, 1800. You can use that to calculate the scales. Most patients, it's just way easier though to do like a 2 per 50 or, you know, 3 per 50 or 4 per 50. When you start getting into the, you know, for my type 1s though, absolutely, because they might be a 1 per 35. And so like when you do that 1800 rule and you're dividing out, right? You might come up with some wonky numbers and it might make it a little bit harder. So, but yeah, for my type 1s where it really makes a difference, yeah, they might be 1 per 35, they might be 1 per 42, like they might be something really specific. But I find you can use that as a rule of thumb, but I find for your type 2s, you're probably just gonna want to stick with something easy. 2 per 50 is going to cover like most people, right? Which is the same as a 1 per 25. So makes it easy peasy for them to calculate, because they're going to be doing this in their head. As much as I would love them to carry around their scales and take it with them to restaurants and stuff like that, most of them are doing this as mental math. And so I sort of recognize that like 2 per 50 is about easy for people to estimate. When I start getting really fancy with the ratios, I think it's harder for adherence. Cool. I think we worked our way through it. We're a little bit over time. If there's any other burning questions, feel free to give me a holler. I'm at jmacd@umich.edu.
Thank you so much, Dr. Iyengar. We really appreciate you being here today and sharing this knowledge with us. All right. Hope everyone has a nice weekend. We will send out the slides and the CME handout so that you'll have access to those, and we'll get the video posted on our website shortly. Hope everyone has a good day.